Good evening, members, and welcome to today's webinar. And the presenter for today is Dr. Joshua Memo, pharmacist working in Meru County and health economist. So I'd like to remind all of you that kindly remember to subscribe to the event in the PPB portal. You can search using the keyword economics, and then you'll see the one with the PSK Meru branch. As Dr. Meme prepares and as we wait for more people to join, I think we can be using the webinar chat, whereby there is a chat there. You can introduce yourself, say your name, where you come from, and what you are looking forward to today's presentation. Also, if you have any question, kindly remember to tap the three dots if you're using Android phone, or click more, and then there is a tab for question and answer. Write your question there so that it can be responded to later after the presentation. Kindly remember, once we are done with the presentation, it will be uploaded in our YouTube channel, which can be shared later. And also, if you need the sites, you can inform us, and they'll be shared. I need someone to confirm actually when audible well enough for everyone. Someone can confirm. Dr. Joshua, can you hear me?
Yes, I can hear you, Doc.
Thank you, Dr. Ali. So you can be sharing your views. You can be saying where you're from. I see we have Dr. Joan from Western Branch. Karibu sana Daktari. We have Dr. George. Karibu sana Daktari from Kakamega. We have Charity. Karibu Daktari. We have Dr. Susan. Karibu sana Daktari. We have Dr. Jamila. Karibu sana Daktari from Bungoma. We have Dr. Kidenya from Meru. Karibuni sana Daktari. I think we are waiting a few more people to join, and then we'll start shortly. Kindly remember, the presentation is being recorded, which will be shared later in an YouTube channel. So we are waiting for just maybe a few more people, and then we start. You can see Dr. Timothy. Karibu sana Daktari. Dr. Patel.
Thank
Dr.
you.
Jitesh. Karibu Daktari. Dr. Miriam. Dr. Peter. Karibuni sana today's webinar. You have Dr. Githinji from Tana Earth branch. Karibu sana Daktari. You have Dr. Kubai from Mount Kenya East, and no, we have Dr. Kubai Kananu from Mount Kenya East. Our neighbors here. Karibu sana Daktari. We have Dr. Mudhuli Geoffrey from Meru County. Karibu sana Daktari. We have Dr. Chaitanya from Nairobi. Karibu Daktari. So my name is Dr. Justus Mutuma Kamunde. I'm the today's moderator working in Meru County and Meru Referral Hospital. Hoping soon it will be a level 6 hospital. So you will be sending referrals from all over the country here in Meru. You have Dr. Kelly from Meru. Karibu Daktari. Dr. Hilary. Karibu Daktari. Just a reminder, if you have any questions, kindly tap the three dots and you'll see a question and answer section. We are hoping not to mix the chat boxes with the questions. And after the presentation, if you may wish to speak, kindly raise your hand and we will be in a position to allow you to speak. So we'll start in the next 2 minutes. I believe majority will have joined. Dr. Joshua, I think
Yes,
we
Doc.
are quite a number. So kindly take the floor. And to remind those who have just joined, those who have questions, kindly tap the three dots, write your question in the Q and answer. If you may wish to speak or ask a question verbally, you can raise your hand and you'll be allowed to speak. We hope you'll enjoy the session. Karibu sana, today's presenter, Dr. Joshua Meme. Kindly take over.
Good evening, colleagues. Thanks for joining. I hope you can all see my slide.
Yes, we can see them, Dr. Ali. Can you put them in
Good.
slideshow, presentation mode?
Okay, let me move there just a moment. Yes. So, concepts in health economics for a pharmacist. That is the topic for today. My name is Dr. Joshua. I'm a health economist working in Meru County. And today's session is all about concepts in health economics. We want to call them the basic concepts, or rather the bare minimum, or rather the definition that you need to know before you interpret or you read an health economic report. So these are just the basic concepts that you need to know. And then learning objectives will span from defining the key health economic concepts, explaining economic evaluation methods, and then applying them in pharmacoeconomics. And I'll start from the simple definition. What is health economics? So health economics is the study of how limited resources are allocated so that we can be able to improve health and healthcare. And as we do this, there is efficiency, effectiveness, value, as we watch behavior of the healthcare systems. So in simple terms, we are trying to answer questions like how healthcare services are funded and delivered, the costs and benefits of medical treatments, how to use the scarce resources that are there to efficiently improve the public health, and lastly, the economic impact of a disease or health policies. So in a few words, the resources are scarce and we need to allocate them in a manner that is efficient, is effective, and it's responsive to the behavior of the healthcare system in that particular region or area. So when you talk about efficiency in healthcare, you're basically talking about using the resources that are there. And when you're talking about resources in the healthcare field, you're talking about the money, which is basically used to do almost everything. Starting from hiring, buying equipment, buying the HPTs, okay? The medicines, of course, we are guided by the essential medicine list. And many a times we are not able to stock as per the EML list. The healthcare workers, okay, the specialists are not everywhere. They're limited. The equipment, and also time. And they're trying to allocate all these resources in a manner that maximizes the health benefit. And in my presentation, I like to use examples because it's through examples that you get to understand or rather to digest these concepts. So in this scenario, think of two hospitals that treat the same disease. And Hospital A spends less money and achieves better patient recovery, while Hospital B spends more money with poorer outcomes. Okay. So it's true to say that Hospital A is considered more efficient in this scenario. So whatever resource that you're allocating, may it be the equipment, may it be the medicines, may it be the specialists that you have, may it be the personnel, may it be the money, you need efficiency. You need efficiency. In other words, you need to allocate it in a manner that you derive utmost utility from it. Okay, utmost utility from it. We are talking about effectiveness in healthcare. Basically means how well a treatment or a program or a healthcare intervention works in real life conditions to improve the health outcomes of the population at large. So think of a scenario whereby you have a vaccine that reduces disease in the community, or a hypertension drug that actually lowers blood pressure in ordinary patient is termed as effective, meaning it's working. Okay. So whatever program, whatever treatment intervention that you're talking about needs to be effective. It needs to solve the problem that is already there. And lastly, I've talked about in a manner that is responsive to the healthcare system. We're talking about a healthcare system here. Yeah? This basically refers to the benefits or health outcomes gained compared to the resources or cost used. Let me give an example. If a vaccination program prevents many illness at a very low cost, it's true to say it provides high value. So in health economics, we will say that value is often assessed through the cost effectiveness of an intervention or a medication, the quality of care, the patient outcomes, or the patient satisfaction in general, which is a parameter that is defined by many factors. So as you do all these, you need to ensure that efficiency, effectiveness, and the response to the value of healthcare system are respected or adhered to. So behavior of healthcare system refers to how the healthcare system functions and how people within it act and interact. It's true to say it includes how patients seek healthcare, the health-seeking behavior, which is directly proportional to the level of education in a particular region or area, how doctors make a treatment decision, and how the hospital managers manage the resources in that particular setting. So, a very good example is if a patient avoid hospital because treatment is expensive, this can be viewed as a part of healthcare system behavior. In other words, when you're talking about behavior of the healthcare system, you take into account a number of factors, for example, level of education, either formal or informal sector, which could be thought of as where the majority of the population lie, because things like insurance or health cover is directly proportional to either formal or informal sector, whereby the formal sector tend to be majority of them to have a cover, and the latter is the opposite. And this will actually dictate how they respond to an healthcare system. And of course, all this is tagged or you're tagged to the cultural factors in that particular region, okay, in terms of their health seeking behavior. So when you're to talk about the key economic concepts, we'll start with the first basic one. We started by saying all these resources, factors of production, are scarce. They are not enough. Okay, it's true to say that they are limited. But on the other side, we have the human wants and healthcare needs unlimited. So in economics, we are trying to match these two, and we can only achieve this if we have the limited resources allocated in such a manner that you get the maximum out of it. Okay. So it's true that a hospital may have limited medicines, limited staff, limited funds. And this is an argument that revolves everywhere, not only in this country, but it's a global thing. At no one particular time, you'll always have enough of what you need. Okay, it's all a matter of giving priority and allocating as per need. Okay, if you look at any setup that you're in, whichever hospital that you work in, at no one particular point that the staff will always be enough. At no one particular point that the medicine will always be enough. So the whole idea of health economics is you try to allocate the little that is there to suit the maximum number of individuals in that setup. A very good example is the use of the essential medicine list in our level 2, 3, 4, and 5 hospitals. In terms of procuring medicines, you make sure that you only procure those molecules that will benefit the maximum of the population. Okay. So from this whole idea, you get to agree with me that you allocate the resources where it's needed most by the largest number of the population. You allocate the resource, may it be manpower, may it be medicine, may it be money, may it be infrastructure, to where it will benefit the maximum population. And that is all about economics. Or rather, that is the basics in economics. The next guy is a choice. I think I've already talked about it. So a very good example is choosing whether to spend more money on vaccines or cancer treatment. You need to make a choice. In this scenario, you have a vaccine that, for example, the HPV vaccine that is given to the population or female population of under 8, so that they will benefit them 30, 40 years from now in terms of cervical cancer. Okay. Another thing that will guide you is that prevention is better than cure, so they say, and indeed it's true. So it's you rather invest a lot of money in prevention because it's cheaper that way. Okay, it will reach a larger population that way. You'll benefit more people that way than treating the same population suffering from the same condition. So my argument is that even in the cancer profile in our county, it's economically viable and sound to invest more money in preventive, early screening and diagnosis interventions than spending the same money in treatment of stage 3B or 4 going upwards of the same cancer. Okay, it makes a lot of economic sound decision if you invest this money, the same money, in prevention than in treatment. Okay, at the end of the day, the more people will benefit from the vaccine than using the same money to treat the same cervical cancer at a later stage, okay, where the prognosis is really poor. So a choice has to be made at the end of the day. Opportunity costs. This is the value of the next best alternative that is sacrificed when a choice is made, okay? A very good example is money used to buy an MRI machine cannot be used to buy ambulances. In other words, the moment you've allocated that money, it's always an economic sound decision to look at what other alternatives were there for me to invest this money. From all these alternatives, where am I deriving utmost, or rather the most benefit from? So an opportunity cost is just a concept that helps you visualize what you've lost, okay? What you've lost by choosing this decision as opposed to the other one, okay? As opposed to the other one. So equity, as you decide on the intervention or treatment that you want to initiate or start, equity must be honored. So in simple words, equity is fair distribution of healthcare services and resources among people. Many a times it's very difficult to achieve equity because of geographical, sex, age distribution. So an example is rural and urban population. Both need to have access of essential medicine. As I've said earlier, it becomes very difficult to achieve equity because of number one, geographical distribution. For example, you'll see that in any setup, community setup, you'll find majority of the healthcare centers are in towns. Okay, so this leaves those guys in the rural setups with little or no access to these healthcare centers. So, as I said earlier, anytime you want to initiate an intervention, uh, the urban guys are always at an upper hand. They're always favored, in other words. So, fairness is not there. Fairness is not there. And then, because of these economies of scale, basically, you'll find equity tends to be asymmetrical. Okay, it's not equally distributed among the population because of age, location, sex. Okay, so it's very hard to achieve this, but many a times when initiating a program, when running a program, when initiating a treatment schedule, it's very good to look at equity. So you're talking about equity. There are basically two types of equity. Talk of horizontal equity and vertical equity. Yeah? So horizontal equity is just as the name suggests, is the same healthcare needs should receive the same treatment or level of care. So if you have two patients with the same disease severity, they should have equal access to treatment regardless of the income, gender, or location. Okay, that is horizontal equity. They tend to have the same healthcare needs. Well, in vertical equity, it's people with different levels of need should receive different levels of care according to their needs. Okay, a very good example is a severely ill patient may require more healthcare resource than a mildly ill patient. Okay, so in equity, you give as per need. Okay, you give as per need. You're sharing the same commodity, but you tend to distribute it as per need. Okay, and in such a scenario, you'll have respected both the vertical and horizontal equity. Many a times, equity and equality, we tend to confuse the two guys, but they're totally different. When we're talking about equality, equality is everyone receive the same healthcare service. Everyone is given the same opportunity to access care. For example, a government provides the same number of malaria drugs to every county, regardless of the disease burden. So, health system often aim for equity rather than strict equality because different populations have different healthcare needs. Okay, so equality is basically you distribute as per need. Okay, as per need, and then we have a picture there that help us visualize these two guys. Which are closely related but not the same thing. Okay. Inequality you give regardless of what they really need. Inequity you give based on what they really need. Okay. So in the first two photos, you can see those guys. I believe they're watching a baseball game. So inequality you award a place to stand so that they can all watch. But it's clear the guy on the right is not seeing anything. Okay. He is disadvantaged because of height. But in equity, you give as per need, and then and the need here is to be able to watch the game. So the guy on the farmost right is given more crates to stand on. That is two crates, and then the second guy is given one crate, and then the first guy is not given any crate because you can already see the horizon. You can already watch the game. So equality and equity, very easy to confuse these two guys. But basically, they mean as illustrated in those photos. Okay, illustrated in those photos. So in many a times, it becomes very difficult to achieve equity and equality. But many a times we tend to prioritize equality as opposed to equality. I mean, many a times we tend to prioritize equity as opposed to equality. Okay. A very good scenario is the allocation of the LLINs, that is the medicated nets, for prevention of malaria. For example, in Meru County, you'll find that we have only two areas that we prioritize, or rather we give as per need. That is Igembe Northern, Igembe Central, and Igembe South. The other regions, we no longer give them nets because ideally they don't need it. Okay, so if you were to scrutinize this, you'll realize that it's all about of these economies of scale and economies of scale. You're located where it's needed most. Okay, where you derive utmost utility of it. Okay, where you get the most benefit of it. Okay, and then the next concept is the issue of cost effectiveness. And cost effectiveness here is comparing the cost of an intervention with the health benefits it produces. How effective is it? It's actually one of the ways of uh, economic evaluation of an intervention. A good example is determining whether vaccination is cheaper and more beneficial than treating the disease later, as I've said earlier. Okay. So cost effectiveness analysis evaluates the different treatment or programs by comparing the cost involved with the health outcomes achieved at the end of the day. So now that you're talking about the costs, the cost involved. So costs in this scenario refers to all resources or expenses used in providing a healthcare service or a treatment or a program. So in economics, you look at all these costs and there are basically four kinds of cost, or rather four types of cost. And the first one is what we tend to see. Okay. And this is the direct medical cost. And this refers to all the expenses directly related to the treatment. For example, the cost of buying medicine, the cost of laboratory tests. Okay. And then we have direct non-medical costs. For that patient to come to that chemist of yours, for that patient to show up in that hospital of yours, there's a direct non-medical cost. These are things like transport to that facility of yours. Okay. It's a non-medical cost. It's a cost incurred indirectly for this individual to get healthcare services. Okay. Now that this individual has missed going to work that particular day, they'll also incur what is referred to as indirect cost. This is the loss of income, for example, due to sickness. They didn't go to work. They were busy looking for healthcare. That is an indirect cost. It's a cost that has been incurred. It's actually a loss, so to think of it. But when you're doing economic evaluations, you tend to consider this, especially when the pay is on the patient perspective. And lastly, we have intangible costs, which are basically non-monetary. Many a times they are difficult to measure. An example is the pain or stress that a patient undergoes while undergoing treatment. Okay. We tend to classify them as intangible costs. So those are the four main kinds of costs. And when you're doing an economic evaluation, you tend to consider all these, what we refer to as a societal perspective. So anytime you're doing costing in health economics, there's only one question: who is bearing the cost? In other words, whose cost and benefits are you considering when evaluating this intervention? At the end of the day, who is going to bear this cost? Okay, so Seattle is the broadest. This is a society. What the society has to shoulder. Okay, so Seattle is our broadest, and then we have the healthcare provider. Is it the hospital that is bearing this cost in terms of the gloves used? The healthcare provider who is going to award these services, the medicines used. Okay, that's the healthcare perspective. And then we have the patient perspective. The patient basically pays what he or she receives. And then lastly, we have a payer perspective. A payer is a scenario whereby you have a program, for example, an intervention, which is funded by a partner. So when doing costing in health economics, basically you're trying to calculate the cost vis-a-vis the benefit. Okay. The index that you get, the index that you get is what will dictate which intervention makes more economic sense. Okay. So as it pertains to cost, it's important to know who is paying. Is it a partner? Is it the patient? Is it the facility? Okay. Or is it the society? Society is termed as the broadest because in the societal perspective, you look at all these, what the patient loses if he or she doesn't show up for work, what the patient incurs as in terms of transport, in terms of the caregiver incentives, what the patient pays in the lab, in the pharmacy, in the registration, okay, all that. So very important to know the perspective in which you're doing your costing. Now that you've said that you need to come up with a cost and then divide it with the outcome, so that you get the cost per unit at the end of the day. And it's the cost per unit that will dictate which intervention is cheapest, or rather, which intervention you're deriving utmost utility from. That is what you're looking at. So the economic or population health outcome, they are used to compare interventions. So many a times when you look at those health economics reports, you'll find things like quality adjusted life year gained, what they refer to as a quality, okay? Quality adjusted life year gained. And then many a times you'll see disability adjusted life year averted, which is a DALI. Conceptually, these two guys are opposite, okay? These two guys are opposite, okay? It's an opposite concept of each other. So in real life, you are trying to gain a quali and avert a DALI, okay? And then you'll also see life expectancy improvement because of a certain medication. The life expectancy improved from 40 to 50. And the disease case prevented in terms of transmission, especially to uh, communicable diseases during modeling. During modeling. So let me spend a few minutes on these first two guys, Aquali and Adali. Okay. Quality adjusted life here, that's Aquali. In many of these interventions, we are trying to improve Aquali and avoid Adali. Adali is a disability adjusted life here. So qualis tend to measure health life gained, while DALIs tend to measure health life lost. Okay. So the two guys will be used interchangeably. And in quali, we tend to evaluate the benefit of a treatment or an intervention. The quality adjusted life years, for example, okay, I have a graph after this. I think it will be very clear. And then a DALI is a measure of disease burden. Okay. So as I said earlier, the two guys tend to mean the opposite side of the fence. So in a quali, you have the higher the quali, the better the health of that individual. So you'll find that quali are measured from 0 to 1, and then they are given weight as per the level of care in that particular country, which is directly proportional to the GDP of that particular country. The quality of life in that particular country, so to think of. And then the DALIs are measured from 1 to 0. Okay. Actually, it's an in of the other guy. Okay. So the higher the DALI, the worse the health. Okay. So we'll find QALY being used in cost utility analysis and a DALI being used in burden of disease studies. So QALY basically means the total life lived by an individual. So either the good life plus when the disease occurred. While a DALI is the quality that has been lost because of a disease, plus the life that the guy did not live. Okay, they died prematurely because of a particular disease. So the goal of a QALY is basically to maximize quality and length of life. Okay, while the goal of a DALI is to minimize the disease burden. Just to make this clear, we have a graph there. On the y-axis, you have the health utility measured from 0 to 1. And on the x-axis, you have the age measured from 0 to 30 or even 50 years. So think of a scenario whereby we have an individual who was born in perfect health at life 0, or rather at age 0 here. And then at 20 years, the individual got HIV, and he or she started taking medications. He or she started getting opportunistic infection. So the quality of life dropped from 1 to say 0.7. And then at 0.7, they started antiretroviral therapy, which was able to extend their life up to 30 years. And then at 30 years, they got an opportunistic infection and they died at the age of 30. So this individual is in a country X, say Kenya. And ideally, if this guy was still in Kenya, the life expectancy, LE here, is 50 years. But this guy died at 30. So this guy has already lost 20 years. Okay? Years of life lost. That is the YLL, years of life lost. Okay? So the QALY is here is a life lived in totality, either in good health or in poor health. So it's from 0 to 30, and that is what constitutes the QALYs. Okay? So 0 to 1 is just an arbitrary figure, which is normally weighted. You give it weight based to the locality of this individual. These weights are normally given in the WHO pharmacoeconomic platform. They are there. You can see the weight associated with an individual, a male individual living in Kenya, and so on. Even the life expectancy, it's given in the pharmacoeconomic platform, WHO platform. The expected life years of an individual, a male or a female in a particular country. So it's against those parameters that we're able to add weight on whatever value that we have in this graph. So the QALYs are the life years lived. And then the DALYs is a summation of the years lived with a disability plus the years of life lost. Okay. So when you're trying to initiate a new molecule in the market, a new intervention in the market, you always talk about it in terms of the QALYs gained or the DALYs averted. Okay. So you'll say molecule B will avert 30 DALYs per individual. Okay. And this is what they mean. Okay. This is what they mean. It means it will like extend their quality of life, though not at that expected quality that of a normal healthy individual. Plus, the years averted instead before death. Okay, so that they can reach their maximum potential. So many a times you'll find qualis and dalis being used, and that is the logic behind it. That is the logic behind it. A very good parameter, a very good parameter when you're reporting these economic evaluations. Now that you're talking about economic evaluations, an economic evaluation is a systematic comparison of the cost and consequences, that is the outcomes of two or more healthcare interventions. So economic evaluation basically compares the costs and the outcomes. And it's very important because it will support decision making in terms of which intervention are you going to take, which intervention are you going to implement. So you talk of types of economic evaluations. There are four kinds of economic evaluation. Starting with the first one, the cost minimization analysis, CMA. This is used when you have the same outcome but different interventions. So used when two interventions have the same outcomes. So only the costs are compared. Okay. As a pharmacist, a very good example is choosing a cheaper generic medicine when it works the same as the branded drug, which is more expensive. So if the outcome is the same, of course, you'll go with the generic molecule. You'll go with the generic molecule. Okay. Many of those who are running pharmacies, in such a scenario, you look at the profit margin. Okay. The profit margin between these two guys. Okay. That is from a pharmacist perspective. But ideally, you're supposed to look at the cost. Ideally, you're supposed to look at the cost that is being bared by this patient. Okay. That is being bared by this patient, because the patient doesn't know about the profit margins. You're the only one who tends to know about the profit margin, which at times it's a little bit unethical. It's a little bit unethical because majority of us, of course, will go for the cost. Whereas you can get the same molecule, a cheaper one, but by the virtue of the fact it has a smaller profit margin, you will dismiss it and sell the guy with a bigger profit margin. And then we have cost effectiveness analysis, which compares costs with outcomes. And the outcomes in this scenario in cost effectiveness analysis are measured in terms of life saved, cases prevented, or blood pressure reduction. An example is comparing two malaria treatment based on cost per malaria case keyword. Okay. So the smaller the CEA value, the better or rather preferred the intervention. Okay, because it's cost per unit. How much are you using to achieve a particular unit? Okay. And then we have cost utility analysis. This compares the cost with outcome adjusted for quality of life. Okay. The cost utility analysis tend to use the DALIs and the QALIs. So a very good example is comparing dialysis and kidney transplant using the cost per QALI gained or the cost per DALI averted. Okay, per the DALI averted. As we had said earlier, the QALI is measured 0 to 1, the DALI is measured 1 to 0. Okay, in QALI, you have perfect health and 0 is death. But in DALI, 0 is disability and 1 is perfect health. Okay. So if you are to look at these in a summary, those guys will look like that. So it's up to you to focus on what is compared. How are you going to measure the outcome of your intervention? The measurement unit, is it a QALI? Is it a natural unit? Is it a cost? Is it a net benefit? Okay. When to use each of those interventions, evaluations rather. And then we have a summary at the bottom there. So our cost minimization analysis, we said the same outcome. You're looking at the guy that has minimal cost. And here's when you're looking at the cost, it's very good to look at the cost perspective. Who is bearing the cost? Is it the patient? Is it the payer? Is it the society? Or is it the hospital? Okay, because the perspective will basically define differently. Okay. So the key component is economic evaluation will help decision makers to choose the intervention that provides the greatest health benefits for the resources available. And the idea here is to use the little resource that is there for maximum gain. For maximum gain. If you like it, we talk of deriving maximum utility from your investments. Okay, deriving maximum utility from your investment. So those are the four basic economic evaluation methods that are there that help us to make a decision. That help us to make a decision. So going back to the first one, the cost effectiveness analysis is used to compare the cost and health outcomes of two or more healthcare interventions. It helps to answer the question which intervention gives the best health outcome for the cost spent. So if you divide the two, you get what we refer to as the cost effectiveness ratio, which is basically the total cost over the health outcome. So the smaller the number, the better it is. The better it is. Example, malaria treatment A costs 10,000 to cure 100 patients. A malaria treatment B costs 15,000 to cure 120 patients. So the cost effectiveness ratio for treatment A you'll get is 100 shillings per patient cured. And the cost effectiveness ratio for treatment B is 105 Kenya shilling per patient cured. So in real terms, you'll say that treatment A is more cost effective because it costs less per patient cured. As I'd said earlier, the smaller the ratio, the better it is. So this is cost effectiveness. When comparing two outcomes, two treatment interventions that have the same outcome, it's very easy to compare, to confuse it with what we refer to as ICER, which is incremental cost effectiveness ratio. Okay, just as the name suggests, is the extra health benefit worth the extra cost? So in incremental cost effectiveness ratio, you already have an intervention that is running, and you want to add another service on top of it. Okay, so ICR is basically used when you want to add on to, okay, a treatment intervention, a treatment strategy. Think of a scenario whereby you have an HIV testing, and this is a payer's perspective. Okay, a partner is paying. An HIV intervention whereby you have a screening and testing for patient for HIV. And on top of it, a partner wants to come in, and this partner has an idea. Instead of just testing and referring this patient to the CCC or otherwise, you want to test. If you find them positive for HIV, you want to trace the partners, okay, and also treat them for HIV. At the end of the day, both interventions help the individuals to know their status and to control it. So an ICER, incremental cost effectiveness ratio, which is basically the cost of the new intervention minus the cost of the old intervention divided by the effectiveness of the new intervention minus the effectiveness of the old intervention. Whatever figure you get as an ICR, you normally compare it as to the willingness to pay by the partner. Okay. And in developing countries, you'll get the willingness to pay being compared to, or rather being proportional to, the GDP of that particular country. So you'll find that ICR ratio is considered, or rather intervention is considered cost effective if the ICR value that you obtain is less than the willingness to pay in that particular country, which is synonymous to the GDP of that particular country. Yeah? So according to the WHO platform, the ICR ratios for various interventions will vary from developing countries to developed countries. Believe it's $100, $100 in developed countries, $50 in developing countries. Last time I checked, it keeps on changing depending on the status of a country. So this is a very good example. You have intervention A and B. The cost of A is 10,000, the cost of B is 18,000. The patient keyword are 80, the patient keyword in B at 120. Then you get the difference in these. So 18,000 minus 10,000, you get 8,000. And the effectiveness is 120, and 80, you get 40. So the ICR in this scenario, you'll find it's 200 Kenya shillings per additional patient keyword. So the 200 that you get in a developing country like Kenya, you'll compare it to $50, which is basically 50 times 130. So if it's less than the GDP of that particular country, then the intervention is considered effective, cost effective. If it's above the willingness to pay, the intervention is considered non-feasible. So on the other hand, the ICR means drug B cost an addition of 200 to cure one extra patient compared to drug A. So decision makers then determine whether that extra benefit is worth the additional cost. So ICR in CEA, cost-effective analysis, we say the smaller the number, the better. Okay. In ICR, we say it should not go above the willingness to pay in that particular country. Okay. So ICR, CEA, those terms will be used now and again. Okay. So willingness to pay is used as a threshold to decide whether an intervention is considered cost-effective. And the ICR result is compared with the willingness to pay threshold. Okay. So if I was to present all that information in a diagram, it will look like that. So we have cost-effective analysis, which basically compares the cost and the health outcome of two or more interventions. And outcomes are measured in natural units. That is case keyword, life years gained, and millimeters of mercury reduced. Okay. So the cost-effective analysis looks at each intervention separately. It tends to calculate the average cost effectiveness of each intervention and helps rank options from the most to the least cost effective. Does not show the additional cost for an additional benefit. Okay. So cost-effective analysis is basically the cost per unit outcome. Okay. And the smaller the figure that you get, the better. Rather, that is what is considered. On the other side, the incremental cost effectiveness analysis tends to look at an additional cost. And the interpretation is whatever value that you obtain from this is compared to the willingness to pay. It should be less than the willingness to pay in that particular country. And that is how we are able to say an incremental service is cost effective or not. Okay. So that is a summary. That is a summary of all the noise that I've been making earlier. So why is health economics important for a pharmacist now? This is a pharmacist forum. Number one, we start by saying it promotes cost effectiveness of medicine use. And I've given you a very good example, choosing a quality generic medicine instead of a more expensive brand when both work equally well. In other words, when you're getting the same benefit from these two molecules, okay? When you're getting the same benefit from these two molecules. Number two, it supports rational use of drugs. So pharmacists will help prevent overuse of medicines, incorrect prescription, especially where we have drug-drug interactions. Okay. It promotes drug wastage. And health economics is very core to antimicrobial resistance. Because at the end of the day, what you're looking at is the patient outcome. As you try to reduce the healthcare cost. Okay. The healthcare cost. Number three, helps in pharmaceutical supply management. So pharmacists, especially sub-county pharmacists, the hospital pharmacists, you are in charge of procurement, storage, distribution, and inventory control in the various sectors that you are in. So health economics helps ensure limited medicine budgets are used efficiently. Okay. In the drug management cycle, so to speak, of, it comes in handy. Try and reduce the wastage and maximize the population gain from the little that you are accorded in terms of budget. Number four, supports policy and formulary decisions. The other day I saw MTRH has a formulary. So there's a clause in this essential medicine list that you select molecules that are of sound, scientific sound, and that are cheap, okay, quote unquote. So when you're coming up with a hospital formulary, when you're selecting essential medicine from the list, when you're working with insurance reimbursement system, economics will come in handy. Okay. Important in public health programs. You can see pharmacists being involved in TB, HIV, malaria, vaccine, or even AMR programs that tend to apply the key concepts in health economics. And these will span from allocation of resources efficiently, reduction in medicine wastage in terms of expiries, evaluation of program outcomes in terms of effectiveness, and general improvement of healthcare planning. Number six, improves access to medicine. As I said earlier, the use of essential medicine lists as per your level of care in terms of procurement, drug pricing, insurance reimbursement, that all come together to try and ensure there is equity in healthcare provision. So these support policies that improve patient access to essential medicine, which ultimately improves access to medicine and reduce irrational prescribing. And lastly, health economics will assist in decision making because pharmacists tend to use cost-effective analysis, cost-benefit analysis, or even cost-utility analysis in trying to evaluate the outcome of various interventions in terms of programs or even medicines. So to determine which medicine or treatment program provide the best value for your money, you have to come out clearly. You have to analyze the program critically. So the key takeaways are resources are limited and we need to allocate them efficiently in a way or rather in a manner that derive maximum utility from them. And pharmacists are key as it pertains to healthcare outcomes and medication use. Okay. The value is not really the cost. Okay. As we've seen that the profit margin of pharmacies is not really the cost that that patient has incurred, because there are other indirect and intangible costs that the patient tend to incur. So when you're talking about economics, you need to put all of these in consideration. Okay, you need to put all these in consideration. So I didn't have much to share. That is all. Not unless there is someone with a question. Not unless there is someone with a question. You can take a question or a concern.
Thank you
Any
very much,
question?
Daktari. This is an informative session. You have done well. I think I've learned a lot. There is a lot in economics, and pharmacist roles in the economics. And actually, I think we'll be referring to the knowledge we have gained today. Kindly let's appreciate our today's presenter, Dr. Joshua Meme. This was very informative and eye-opener. I think most people who learn pharmacies and who are sub-county pharmacists who are head of procurement, you have learned a lot of this and the formulas they are in. So we had advised that those with questions, kindly you can use the question and answer tab so that the questions can be answered. If you wish to ask the question verbally, you can as well raise your hand and we will unmute you to talk. I think, Dr. Joshua, there is a question that was asked in the webinar chat. The question was on ICR. Do we consider at nominal GDP per capita or at PPP, the use of purchase power? Maybe you can take time and answer that one, Dr. Ali, as we wait for some more questions or comment from the attendees. Dr. Joshua?
Okay, thank you very much for that question. So the way I understand it, incremental cost effectiveness ratio, whereby you're adding a particular service to already what is existing, it's only considered cost effective when when the ICR value is less than the GDP value. So something that I've not presented in this platform, we don't take the nominal GDP because many a times in costing, economic costing and evaluation, we tend to discounting. So when you're using a nominal GDP, which is basically the value of the final good and services produced in a particular country at a particular time, okay? So if you consider a particular time, look at a scenario whereby the intervention here has a long time horizon. A very good example is a scenario whereby you're giving an HPV vaccine to 80-year-old females. But in such a scenario, the benefit is a long time scenario. It's a long time horizon. You're not getting the benefit now.
Dr. Meme, can you
Can you
repeat
hear
the
me?
last few sentences? Yeah, we lost you, but slightly for a few seconds. You can kindly repeat a few
Yes.
previous sentences.
So I was saying, anytime that you're doing cost in economics, you tend to look at the value of money at that particular time that the patient will be getting the benefit from it. So when you're talking about nominal GDP, which is basically the value of that good or service at that particular time, then it falls outside the equation simply because you've not accounted for discounting. In other words, you've not accounted for inflation, in simple words. It's true to say that over time, the value of most of the commodities tends to go up, ideally. Ideally, that is for commodities that don't tend to wear out Okay, quote unquote. So when you're doing ICR, you normally discount it. You normally discount it to when this patient will get the benefit. And I've given an example of HPV vaccine. The patient gets the benefit 30, 40 years later, which is basically cervical cancer averted or life years gained simply because of this vaccine that he or she got, or that she got at an earlier age. So not the nominal GDP. Okay, I hope I'm clear. So nominal GDP, no,
Yes,
no,
Dr.
no, no. Okay, you need to account, you need to discount it. What will the value, what is the value when this patient is getting the benefit? That is a time horizon question. My thinking though, not unless there's someone with a different school of thought.
Thank you for that question, Dr. I hope it is well answered. And if there is anything concerning the same question, the concerned party can raise more questions or clarification. There is another question, Dr. Please check Q and answer. There's some 2 more questions. Can I read for you?
Yes, kindly go ahead.
Dr. Kome Mudhuli asked, thank you, Doc, for that great presentation. Is the cost of providing healthcare in Kenya or Meru known per capita per annum? I think you can start with that one before we go to the next question, which is Eric Njega is asking, in the case of an expensive anti-cancer drug, what method would be suitable in analysis its suitability for use for a patient in stage 4? Maybe you can start with Dr. Kome's question about, is the cost of providing healthcare in Kenya, Meru, per capita per annum known?
Okay, thank you, Doc, for that question. I'll start by saying that in health economics, it's all a matter of allocating the little that you have for maximum benefits. Okay. So when you're talking about healthcare, we need to be a little bit specific. Which particular intervention are you talking about? And then we need to analyze it. Is it does it make sense? Does it make sense? And as you do this, please bear in mind who is bearing the cost. Is it the insurer? Okay, which some people tend to refer as the payer, or is it the society? Is it the patient, or is it the facility? So once you have the perspective, then you can be able to calculate the cost of that particular intervention and analyze it to make up a decision. Is it economic or not? So you need to be very specific. What particular intervention are you talking about, and who is bearing that cost? Okay, who is bearing that cost? I think I've answered. Number 2, someone else had talked about the anti-cancer molecules. And what was the question about the anti-cancer, Dr. Mutuma?
Yes, Dr. Eric Njega was asking, in the case of an expensive anti-cancer drug, what method would be suitable in analysis or in analyzing its suitability for use for a patient in stage 4?
Okay, that's a very good question from Dr. Ndwiga there. But you're talking about anti-cancer molecules. So many a times, for example, the anti-cancer scenario, for you to say this molecule is better than the other molecule, or this molecule is expensive than the other molecule, you need to have a comparison. That molecule that you're bringing to the market is used to treat stage 4 for which cancer? What treatment options are there for this particular cancer already that are there in that particular country? So you're basically comparing what is there, you can call it treatment option A, and what you're bringing in, treatment option B. Okay? In such a scenario, you look at the first thing, the payer's perspective. Who is bearing the cost? Is it the patient? Is it the hospital? Is it the insurer? Once you get that, then you can be able to calculate all the costs associated with that particular molecule of yours or that treatment intervention of yours. And for example, the anti-cancers, and now that he has mentioned about stage 4, yeah? When I talk about the ICR ratio, we looked at the incremental cost effectiveness ratio divided by, which is basically the effectiveness of that molecule. And the effectiveness in this scenario is the death averted. Okay. For a patient in stage 4, you'll find that in many scenarios, you can all bear witness, the life he has gained or the quality of life or the quality gained, they tend to be very short. Already this patient is in terminal stages. So in many scenarios, you'll find that by the market, as the market dictates, majority of these newcomers or new molecule introduction in the market, they'll tend to lower the prices. But if you are to calculate the ICR of this particular intervention, you'll find that the denominator is a very tiny value, such that even if you lower the price of this molecule that you're bringing into the market, we are not really deriving a lot of utility from it. Quote in quote, either because of market dominance or because the patient don't tend to live long enough to derive a lot of utility from this price reduction. Then you'll find that the ICR, even if you lower the prices, the ICR goes up. Okay. This is what we refer in economics as the southwest problem in economics. The southwest quadrant ICR problem. But even if you lower the price of these generic molecules of yours that you're bringing, or you're trying to enter the market and you're advised to lower the prices so that your molecule can be bought by majority of the population, doesn't really give in. Doesn't really give in. What they refer to as the southwest quadrant problem. So for you to term an intervention as expensive or poor or cheap, which is relative, you need to be comparing with something. Okay, what are we gaining from it? What already is there in the market vis-a-vis what you've brought? Okay, what is the ICR? Okay, so once you have that figure, then you can be able to argue your point out. A very common problem with market entry molecules, especially the short utility molecules. Actually, it's the reason why you'll find that a pharma like Novartis subsidizes molecules for NCDs, okay? Because the utility derived from it is very long. The patient tend to use this molecule for a very long period of time. So you'll find that your denominator of your ICR is a very big figure. So at the end of the day, when you get your ICR, it's a very small figure. What you really want, okay? What you really want and what really makes sense vis-a-vis comparing it to per capita income of a country. I hope I've answered you.
Thank you, Dr. I believe you have answered the question, though I was wondering why Dr. chose to ask about stage 4, not any other stage.
Yes,
but
that's a
maybe
terminal.
comment about that.
That's a terminal stage. You see, sorry to say this, but personally, as I was discussing it with my senior the other day, we have a problem in this country, and the problem is that, for example, in the cancer area, we tend to spend so much in treatment of late stages, that is 3B going above, where we tend to use very aggressive molecules which tend to be very expensive and which tend to have a very large profile of adverse effect and side effects, but the prognosis of our patient is very poor. Instead of us driving or directing that money into late stage management, we need to redirect that finances into early screening and early diagnosis. Okay, that is the only way we are going to walk out of this bottomless pit. So we continue doing what you are doing. You get a relative already in stage 3B, stage 4. Sorry about that, but it's already too late. Let's stop approaching it from a emotional perspective to a scientific perspective. We need to redirect that finances into early detection, early screening, maybe having a screening package even in our SHA, okay, that will actually help us get these conditions early enough, okay, so that we can be able to act on them early enough. And at the end of the day, get a better outcome, or rather a better utility of our money, so to think of it. Thank you.
Thank you very much, Daktari. I think you have clarified very well. Thank you for that. There are 2 more questions to go. The other one of the question is, I was asked in the question and answer by Dr. Hilary Gichuki. He's asking, are you in a position to comment if health economics is recognized as a specialty among pharmacists? We really need them.
Yes, it's recognized. Health economics is recognized. We even have a Health Economics Association of Kenya. Indeed, it's recognized. It's even in the scheme of service among the pharmacists progression line. Another question, Doc?
Yes, thank you, Dr. The other question is, it's in the link, it is in the chat box. And Dr. June is asking, is the high cost equivalent to quality? And how do you balance the thin line of cost effective and quality?
No, high cost is not equals to quality, Dr. June. High cost is not equivalent to quality. All you're looking at is what have you invested, what is the outcome that you're looking at. Okay, that ratio, the smaller it is, the better. The smaller it is, the better. Okay, cost effectiveness analysis, the smaller the number, the better.
Thank you, Daktari, for that clarification. I think we are almost ending the presentation. If there is anyone else who is left out, kindly you can be preparing to ask your question. Daktari, myself, I've learned a lot. And there is something that was bothering me, but you have clarified. Maybe when I go back to the slides, I can get an answer. Not to say what I want to mention as any political, any consequences or looking for blame. I was wondering, there is this initiative by Dr. Kanga, I think by Ilongo Kangata, governor for Murang'a, the mobile dialysis unit. So I was wondering about the cost effectiveness of that and cost minimization. And I was wondering if the 3 dialysis units in that mobile truck could be positioned at 3 different hospitals. Would that be more effective than the truck taking time to drive all the way and using that cost and then the cost of buying the truck itself and the driver? And I believe from your slide, I can go back and apply the formula A and B and get what's more effective about that. Thank you for that, Daktari. I hope there is no one else left out with a comment, with any comment or any question. Daktari, for what I've just said, if there is anything you can help me get the formula correct, you can clarify for me. This is to remind you that please remember to log into your PPB portal and subscribe to today's event. You can use keyword like health economics or health, and then you'll choose the one with Meru PSK branch. And once you do that, remember the awarding of tokens will depend on the number of subscriptions done. Because if the attendees were 500 and only 300 subscribes, it means the rest will not get the CPD points. Daktari, I think there is 2 more questions. I think one is from Anita. Do you currently use health economics to come with your formularies or essential drug list? Dr. Meme, you have a question, if you have an answer to that, you can be answering. And then the other comment, the other question is, why don't our administrations utilize these very noble methods unlike making allocations without any such guidance? So for that one, I think our presenter for today may not be able to answer why the administrators don't use these very professional methods. I think that question would be directed to the admins, specifically to some and not everyone. Maybe Dr. Meme answer this other question about the...
Yes, thank you very much, Dr. Mutuma. To the first question, yes. Formularies, essential drug list. There's a reason why we review our essential drug list every 5 years, if I'm not wrong. Yes, there's a clause in the review of essential drug list, which varies from one country to another, that talks about cost and affordability of molecules. So you only include drugs that have proven scientifically to be effective in terms of managing the condition and in terms of cost. Okay, and it goes without saying, your formulary, it's basically the essential drug list of that particular country, ticked or rather modeled to your level of care. Okay. The other question about the administration not using the noble methods in economics. Let me just give you an example.
The question was, Dr.
Yes.
Yes, I wanted to read the question for you. Why don't our administrations utilize these very noble methods and like making allocations without any such guidances? That was the question.
Yes, and that is what I was running into, Doc. So you can't really say that they're not using it, and I can't really talk for them in this particular platform.
Yeah.
But what
Dr.
But what I can tell you,
Dr. Joshua, can you hear me?
Yes, I can hear you, Doc.
Yes, I think you are breaking and it's like we are losing you. Maybe you can stabilize your positional network so that we can hear you well, Dr.
Actually, I'm not moving. I think it's just
okay.
a network issue.
We can hear you now.
I think it's just a network issue. So I think I've already answered about the formularies and the essential drug list. So for you to be in touch, is that you use the current essential drug list to come up with your formularies. I believe the guys who sat down at the national level to come with the essential drug list have already put in the economics perspective, well, putting down the molecules that are being listed here. Then notwithstanding, remember again, when you're coming out with a formulary, you're given the leeway to use generic names. So it's upon you as a pharmacist, when you're selecting these molecules in their various ordering platform, to put in your knowledge in terms of what outcome you're expecting vis-a-vis the molecule that is there. Okay. The other issue of administration, honestly, I can't speak about that. If they are using or not using, I can't honestly talk about it. But I believe to the best of their knowledge, they are using it. Yes, that is all I can say about it. Dr. Mutuma, can you hear me?
Yes, I can hear you, actually, though you are breaking. I'm not sure whether it is only on my side. I think there was a comment from someone that they can hear you clearly. I think you can rush the last two questions, actually. Time is not our side. You can use 1 minute to answer the last question, actually.
So what tools are available?
What tools are available to pharmacists in hospitals to undertake? Actually, can you hear me? On my side, I can't hear you. I hope I'm the only one. Dr. Meme, if you can hear me, kindly check on your network and respond to that last question. Tools available to pharmacists.
Yes, Doc, I can hear you. So someone has asked about what tools are there in hospital to undertake cost-effective analysis. So thank you for that question. This is a little bit broad question. But for you to handle whatever intervention that you're talking about, you need to first model it. What do you expect from it? Okay, what are the adverse effects, for example, for particular intervention that you expect? Okay, so there are a number of ways of modeling an intervention. Based on the time horizon and based on its probability of occurrence. A very common decision tree, so they call it, is what we refer to as the Markov model. Story for another day, but if you're able to Markov model a decision that, or rather a problem, then you can, with the knowledge of the probabilities, of course, drawn from clinical studies, at the end of the day, you can get the values. You can add values to that tree of yours or decision tree of yours. And at the end of the day, you can come up with a conclusion. Is it effective or is it not effective? Please allow me not to talk about it here. Maybe next time I'll be talking about the various modeling scenarios that are there, or other ways of modeling a problem and calculating based on the probabilities and the weights. Okay, either you get it's a whole big story for another day, but the bottom of the line is, as per now, what we have in our facilities, we have the R starter, which is a program. We also have Excel, but nowadays Excel is really outdated. What we really have that is really working is R statistics. You can look it up, and you can, now that we even have AI modeling, you can look it up and even study it offline if you want to improve your cost effectiveness or economic evaluation analysis. I hope I've answered that, Doc. Hello?
Actually, I think we lost you at some point. I'm not
Oh,
sure, but I think it's a few of us. But I believe you, if I get your message correctly, you said some of the questions, you'll deal with them later because we'll be having some more coming presentations on these health economics. I think this has been a very wonderful, very informative, very engaging presentation. There were so many questions. You have given practical examples, Daktari. Thank you for that, so that one can relate well. I think this was a well-needed presentation, and we may be needing more of this to clarify several of these, and maybe about the business models and many other regarding the economics, and also the serving the population. Remember, the pharmacists, they are those in business, they are those in service, and everyone needs the economics, the health economics, so that they can survive. Thank you very much for that, Daktari. I hope there is no one left out. And if there is any, you can kindly raise your hand. We'll allow you to talk. Remember to subscribe to the PPB portal, and you'll get your point, CPD point within the 7 days. Thank you very much, Daktari, for that. And I think we can all of us appreciate the Daktari for very well answered questions at the very end tail of this presentation today. We have extended our session by almost 30 minutes, and I think it was very much needed. We really appreciate it, Daktari. So I will now allow everyone to leave at their own pleasure as we have achieved the objectives of the day. Have a lovely evening and enjoy the
Thank you and have a good evening.